Okay, so welcome everyone. What we want to do first is give you a landscape of how we came together. So we are primarily, we're a group of women plus one man. And some of us, one man, some of us call, his name is Dr. Sang, but his first name's Charlie, so we started out by calling ourselves Charlie's Angels. But essentially, we're a group of people who have been working together for a long time now. We really enjoy working together and helping women who've been diagnosed with breast cancer. And so we decided to come together and develop a clinic that would serve the newly diagnosed patient with breast cancer. So I don't know if any of you some of you have had your care through UCLA, and while it's a world-renowned quaternary care center, sometimes as an individual patient you can feel quite lost in the process. You have a number of specialists that you're referred to when you have a first diagnosis of breast cancer, and it's a little bit maddening to try and navigate your way through the appointment process and imaging and studies that need to be done. And so this is what you may feel like if you've been bounced around the variety of subspecialty clinics that are offered to a person with newly diagnosed breast cancer. And so we understand that there's a lack of consistency in how we are able to meet expectations, inefficiency in the whole process of getting appointments made, and the urgency that one feels with a new diagnosis. Who is there to help you through this process? And the medical care feels fragmented to an individual patient. So recognizing this, we clinicians came together and said, can we do better coming together and working as a whole? And so can we actually find a way to integrate our services around the patient, perhaps with a navigator who can help see the patient through the whole process. So on the left there is the patient, and on the right is the navigator, and that is the system that we have attempted to build and are continuing to refine and build as we move forward. This is an iterative process that the medical center is watching closely as perhaps a model for how we can care for patients going forward with complicated medical diagnoses. And so here are the team of people you're going to meet tonight. And we're going to start with Ann Hoyt. I'm going to individually, quite briefly, introduce the people. Ann Hoyt up here on the left is the director of the Barbara Court Women's Imaging Center at Santa Monica, UCLA, and she's going to give you a brief overview. Each of us are going to give you a snapshot of what's new and cutting edge in our own specialties for breast cancer and how we are making our own subspecialty personalized for the care of the woman with breast cancer. So Ann's going to begin. We're going to sort of navigate you through the process of a diagnosis, first with imaging. Then we're going to go to our pathologist, Dr. Nicole Dawson, who does the breast pathology. She's going to talk to you about what's new and cutting edge in diagnosis and molecular, our understanding of molecular features of breast cancer. We're then going to go to Dr. Foster, our surgeon, who is primarily specialized in breast cancer, and then to Dr. Sang, who does the reconstructive surgery process, Charlie. And then medical oncology is me, Sarah. And I'll talk to you about the medicines we use in a targeted way to try and treat this disease and prevent it from coming back. And then last but certainly not least, most important, some would say, is Susie McCloskey, our radiation oncologist who has a real interest and specialty in treating breast cancer. And so I want to, because we don't have a picture of her here, and her email is not showing up well because I couldn't deal with this. The slide did this automatically and I couldn't change the color. But Robin, can you stand up and wave? She's our patient navigator who sees our patients through this process. And so certainly if any of you know of anyone who's been newly diagnosed, you can email any of us or get in touch with Robin Dvorak, and she will help get the patient in. Usually within a week. We have our clinics on Wednesday mornings, and we usually are able to see a patient within a week And all of us see the patient together at the same time, go through the imaging, the pathology, and render a treatment plan for the patient as much as we're able to at that one visit, allowing the patient to not have to go to multiple different clinics to get the recommendations. All right, with that, I'm going to invite Dr. Hoyt to come up and give us a brief overview on her specialty, imaging.
All right, it's a real pleasure to come and meet everybody tonight and talk to you. What I'd like to do, let's tell you a little bit about what I do. I'm a radiologist, and my specialty is breast imaging. We do all types of breast imaging. If it can be done in breast imaging, we like to say we can do it. So that's what we do. But today, for the purposes of this talk, I'm going to focus on new and evolving technologies that are related to mammography. So in the last 75 or so years, mammography has come a long ways. The early mammograms, which were done in this country, included the chest, the ribs, and the breast. And over time, the imaging focused down onto the breast. In the 70s, you had those blue mammograms called zero mammograms. And taking you up to the current in the 2000s, we started with the digital mammography. In terms of screening guidelines, this is an area where over the years there's been a lot of controversy, but screening mammography remains the most studied screening test in the world. And the major organizations, the American Cancer Society, American College of Radiology, the obstetrics, the gynecologists, etc., they all recommend routine annual screening mammography beginning at age 40. There's no longer a recommendation for a baseline mammogram at age 35. However, in some women, we do start imaging earlier if they're particularly high risk. When we do a screening mammogram, 2 pictures of each breast are obtained. There's the medial lateral oblique, or MLO view, which is the angled sideways view, and the cranial caudal view, or the view from the top. And this is what normal screening mammograms look like. And what I'd like to draw your attention to first are the medial lateral obliques. You can see here, you have the pectoralis muscle and the majority of the breast tissue included on this view. The cranial caudal view has a smaller portion of muscle and the breast tissue as you would see it from the top looking down. What's most important to recognize here is the breast tissue itself is the white part of the mammogram, and the background gray is breast fat. And that's going to be related to the breast tissue density, and we'll talk about that as we go through and how that's related to the likelihood of detecting a breast cancer if present. When we look at mammograms, the vast majority of what we see is normal, or benign, or non-cancerous. Well under 1% of all findings on mammograms represent malignancies. However, these are a few examples of breast cancers. On the left, you see the little punctate calcium deposits. This represents DCIS, or ductal carcinoma in situ, an early form of breast cancer that's still contained within the milk duct. On the right, though, you see a different image. You see a mass with a spiculated margin. This is a more advanced form of breast cancer. It's an invasive form of breast cancer where the tumor is broken out of the duct and has begun to invade the breast tissue. And what I want you to focus on for the purpose of this lecture tonight is that spiculated margin. That's one of the things that we are going to be looking for when we look for breast cancers in mammograms. So mammography, it's a great test. It's a proven test, but it's not perfect. It doesn't find every single breast cancer out there. And we all know somebody or several people that had a mammogram that didn't show their breast cancer. Having said that, we know in most women why this happens. Most of the time it's related to the density of the breast tissue. That's the biggest factor affecting the likelihood of detecting breast cancer on a screening mammogram. And when we look at women, we know their breast density varies. It's going to vary with their age, their hormonal status, and several other things. So let's look at some examples of breast density and see why this is so important. Here are some examples of breast density. On the left, you've got a very fatty breast We would not call that a dense breast. That's a very fatty breast. And as you move to the right, you move into denser and finally extremely dense breasts. Remember from the first couple slides, we talked about the white representing the breast tissue and the gray representing the breast fat. Well, on a mammogram, abnormalities are actually white. So they're going to stand out in contrast in a fatty gray background. If, for example, you develop this small little breast cancer, you can see how easy it would be to detect in a fatty breast, whereas that same tumor might be entirely obscured in a dense breast. So this is why the density is so important. So what tools are out there? What can we do to better image dense breast tissue? Well, the most commonly used tool is actually breast ultrasound. And unlike mammography, which uses radiation, breast ultrasound uses sound waves. And it allows us to look through the dense tissue and to potentially uncover a mass or an underlying abnormality. On a day-to-day basis, it's our friend. We use it all day long, especially in evaluating women that have breast lumps or that have abnormal mammograms. This is what normal tissue looks like on breast ultrasound. This is a simple cyst. Notice the smooth margin. This is a fibroadenoma, so a benign, non-cancerous mass. Again, smooth margin. And here's a small cancer with an irregular margin. So, what else is out there? Well, I want to tell you about the latest development in breast imaging, and it's called digital breast tomosynthesis, or 3D mammography. You may have heard of it. It's been up and coming for about 10 years or so, actually longer, but 10 years that most of us have been aware of it. And it's now an FDA-approved procedure that we offer at our site, and there are several other places in the country that have it. So how does it work? Well, it works just like a regular mammogram in that the breast is compressed, and instead of obtaining a single exposure, say from the top for a cranial caudal view, the X-ray tube moves in a small arc over the top of the breast, and it obtains 15 very, very low dose exposures at different angles. That information is then fed to a computer, and it's processed and reconstructed. And it's reconstructed into 1 millimeter thick slices of breast tissue that are then stacked up into a volume, and then you can go through them one by one, and I'll show you how this works. By doing this, you're able to see better visualization of fine mammographic detail, and also you can potentially uncover a mass that might be hidden by overlapping tissue above or below it. This is a little cartoon. It's going to show you how it works. So you can see she's getting her 15 exposures in an arc across the top. And then the computer reconstructs these slices, 1 millimeter thick slices. It's going to stack them up into a volume. And now watch as they peel them off one at a time. And focus on the deep breast. See if you see any spicules come out. Did you see that? Okay, so that's what tomosynthesis is, and that is what allows us to look through the tissue layer by layer and potentially uncover a breast cancer. So whenever there's new technology, everybody wants to know how good it is. Well, there's been a lot of studies. They've been done in the US, they've been done in Europe, and elsewhere, and the data has been uniformly good. What we're finding is there is a 27% increase in the detection of all breast cancers, invasives as well as the in situ or DCIS. However, the more exciting news is there is a 40% increase in the detection of the invasive breast cancers, which are the more serious tumors with this technology. So it's very good. Furthermore, fewer women after having tomosynthesis are asked to come back for additional views because the common overlapping breast tissue that will fool us, we're able to usually sort out ahead of time. So that's another nice benefit. I'll show you a couple examples. This one is a 2D mammogram on the left, the traditional. This is a tomosynthesis image, and we're going to go through the stack. So we're going through a fairly thick, dense breast. Watch just above the pointer as the little mass with those spicules pops out. I don't know if you saw it go by, but I'm going to show you a close-up. This is a close-up on the left, the 2D mammogram on the right, the single 1 millimeter thick slice through that area, and you can see how much better you can appreciate those spicules and pick that out from the background. Another example, this is what we call architectural distortion. On the left, the lower breast looks normal. On the right, you see long, thin spicules of distorted tissue being pulled to a central point in the absence of a central mass. This is architectural distortion. This is another breast cancer. Another mass. And my favorite example of a mass here. So besides finding more cancers, it's actually very important that we call fewer women back, because it's very scary to get called back from a mammogram. And this case shows an example of how tomosynthesis helps us with that. The woman came in and she had a regular 2D mammogram on the left, and it looked like she had an area of either an architectural distortion or an underlying spiculated mass. However, fortunately, she had these tomosynthesis the same day. And when you look through, if you focus on this area, you'll see that there's actually nothing there. It's overlapping tissue at different depths that was creating the illusion of a mass. So very powerful tool, very exciting stuff.
Hello everyone, I'm Dr. Dawson. I'm the pathologist who works with this fabulous team, and it's not always, you don't always get a chance to actually meet your pathologist. We're sort of the behind the scenes physician. We work very closely, we're sort of the doctor's doctor, working very closely with all the specialties, including oncology, very close with oncology, radiology, and surgery. And so today I think I'd like to take you through a whirlwind tour of the role of the pathologist in cancer diagnosis. And at the end I'll touch on some of the newer sort of insights we've had over the last decade in terms of molecular analysis of breast cancer, as Sarah alluded to. So let's go ahead and start. So as a pathologist, we're responsible for actually handling and processing all the tissues, including biopsies and surgical specimens. And we obviously make the diagnosis in close correlation in conjunction with the clinical and radiographic features. We evaluate features linked to prognosis, response to therapy, and some of those include margin status, staging of the tumor, and the microscopic and molecular profile of the tumor. Just quickly before I start, just to sort of highlight for you some of the normal breast tissue on the left here is a schematic that shows you the milk ducts, which is essentially the breast is designed to produce milk. It's from these epithelial-lined breast ducts that the majority of the cancers arise. And this on the right is a microscopic image just showing you a normal lobule. It's not actually projecting very well, but these lobules are lined by a few layers of normal epithelial cells, and they have a patent lumen. So step one for the pathologist is actually to handle the gross, the raw tissue. And when we do that, we correlate it with what Anne was talking about, those radiographic images. So we're looking for the lesion, we're identifying its size, we're assessing its relationship to the edges of the tissue, or what we call the margins, and we look for lymph nodes, as well as then subsequently sampling those lesions for microscopic analysis. Now, on the left is an example of an actual cross-section through a large excisional specimen, and you can see the arrow there highlighting a very firm, somewhat spiculated tumor that is very close to the inked margins of the tumor. And we can see we have very different colors of ink around the specimen, which correlates with the orientation of the sample. And the schematic on the right nicely highlights what we consider negative margins if we have normal uninvolved tissue surrounding that tumor mass versus the tumor here on the right that extends to the edge of the tissue and is considered positive, has positive margins. Another example here of a smaller excisional specimen, which is serially sectioned, and the arrows show you the tumor there, which is again right here showing you this irregular mass here very close to an inked margin, and also here at the edge is the biopsy site, which is represented by hemorrhage. And all these areas are sampled subsequently for microscopic evaluation. Now sometimes we can't feel or see the lesion, and we rely on looking for biopsy site changes. And these are very early lesions, and this is an example of a specimen that contains a biopsy clip, which is placed at the time of the procedure. And again, we will take sections of this, and I'll explain this later on, and evaluate it under the microscope. So part 2 is the actual histologic processing, and this is very important. This actually preserves the tissue. It allows us to take microscopic sections to view under the microscope. And the whole process takes a few days. So if you wonder why pathology results aren't coming back, this is sort of the critical phase. It's a minimum of 1 to 2 days, and it's very important for accurate biomarker testing, which is important for prognosis and treatment decisions, which I will touch on at the end. So the result of the processing is a paraffin-embedded block. So that tissue essentially is dehydrated and embedded in paraffin. And from this, we take very thin sections, place it on a glass slide, stain it, and these are our routine sections we examine. We can also stain them for immunohistochemical stains for biomarker evaluation. We can do fish studies for HER2 analysis. We can do additional genomic assays as well on paraffin-embedded tissues. So these are permanently held in the Department of Pathology. If there's ever a need in the future to retrieve your tissues and do additional testing, these are always available to us and for you. So subsequently, we receive the slides. Step 3 is the microscopic evaluation, and this can entail a few slides or many slides. Sometimes we look at up to 100 slides on a very large case, and we closely evaluate all the features, which I will talk about in the next slide. So just quickly, what is cancer? It's essentially an uncontrolled cell growth, which results in a tumor mass. The cells can then invade into the surrounding tissue and spread to distant sites or metastasize. And these changes are reflected in the histologic appearance, the genetic makeup, and the gene or protein expression. And here is, again, that schematic. And just to show you, microscopically, a normal duct has a patent lumen lined by a few layers of cells. And here, you have uncontrolled growth of the cells, but it's confined to the ductal system. We refer to it DCIS. And once it spreads beyond the ductal system, it becomes invasive ductal carcinoma, one of the more common types of cancers that we see. So microscopically, I'm going to blitz through this quickly, but we look at many things, including normal, the precancerous areas, and the invasive tumor. We grade the tumor with a very specialized system called the Modified Bloom-Richardson score. We confirm the size of the tumor microscopically, and we evaluate margins. We also will look at vascular spaces to assess for tumor involvement. Obviously, we'll look at lymph nodes as well to assess for involvement by tumor, and then ultimately we stage the tumor based on the size, number of lymph nodes, and ultimately if there's presence or absence of metastatic disease. The next 4 slides are just microscopic images depicting these things. And again, here you have normal ducts, and here are ducts distended by a uniform population of tumor cells but retained within the ductal system. So it's precancer or DCIS. Here's a larger area of involvement here associated with calcifications that can be seen radiographically. Again, all within the ductal system, has not invaded into the surrounding tissue. And this is a nice example showing you here. The schematic on the left highlights here the DCIS, and now it has the ability to invade into the surrounding tissue. So this is invasive ductal carcinoma and DCIS. When we grade the tumor, we look at its ability to form glands, and in this left-hand example here, it resembles more the normal ductal epithelium, so this is an example of a well-differentiated cancer. And on the right, it's lost its capacity to make lumens, it's not making ducts, and it's an example of a poorly differentiated ductal carcinoma. And lymph node evaluation, this is just to quickly show you an example of a positive lymph node. This is a large area of involvement in a lymph node. And these deposits can be highlighted by special stains, which I alluded to, immunohistochemistry, and this highlights the tumor deposit here in brown. This is very helpful in lymph nodes that look to us negative on microscopic examination, and it can pick up very small, or what we call isolated tumor deposits in lymph nodes, which could be missed on the routine H&E examination. So step 4, the very important evaluation of biomarkers, and those biomarkers we look at include ER/PR, estrogen and progesterone receptors, HER2 status, Ki67, and then I'll touch a little bit on some of the more esoteric testing that we do. And just quickly, this is an example of immunohistochemistry for ER/PR, and normal breast tissue expresses ER/PR. It's involved in cell growth. And here you can see on the left, here is an example of DCIS, positive for estrogen receptor, very strong positive staining. And here a very well-differentiated tumor, which is forming glands, is also positive for PR. And here it's a marker we also evaluate as a marker for cell proliferation, Ki67. And it tells us how fast the tumor is actually growing. And here on the left, you can tell the cancers that's displaying slow growth, so few of the tumor cells are positive, versus the more rapidly growing tumor that shows quite a bit of staining for this marker. Importantly here, one of our tests, HER2, this is an oncogene. It can promote cell cancer growth. And we test for this by IHC. So we test for the expression of the protein here on the left, which you can see this very strong membranous staining. And we also test for the amplification of the gene. And this is an example of normal. We have probes DNA probes here. And this is normal, they're matched here. And here you can see an amplification. And this is consistent with amplification of the gene and predicts that it would respond to targeted therapies such as Herceptin. Now, over the last 10 years, our understanding has deepened with molecular analysis, and we have characterized these new subtypes of tumor based on gene expression profiling. And the majority of the tumors are what we call the luminal A or B types. They make up about 70% of the tumors, and the majority of these are ER/PR positive. There's another group of cancers that are these HER2 positive cancers that are typically ER/PR negative, and then the triple negative or basal-like cancers. And this molecular analysis has allowed us to improve our prediction of prognosis and better treat patients. Briefly, this has also allowed us to do additional testing. Some genomic assays are now available for clinical use, and these are in limited use, and we use them primarily in early breast cancers. And some example of these are Oncotype and Mammograms. So instead of looking at a single gene, they look at large groups of genes. And these can be helpful in predicting recurrence of tumors and also in guiding therapy. And these are some of the ones that we typically occasionally use, which includes Oncotype DX, which requires formalin fixed tissue, and Mammogram. So in summary, accurate diagnosis and appropriate treatment depends on the input of the pathologist, and it requires proper tissue handling and evaluation. And this molecular analysis complements that diagnosis, and it provides for more of a targeted or personalized therapy. And this is a rapidly evolving area and a very exciting area. And with that, I'm going to hand it over to our surgeon, Dr. Foster, for the surgical perspective.
Thank you.
Mm-hmm.
All right, well, thank you again. I'm Nova Foster. I'm one of the breast surgeons at UCLA Santa Monica. I see definitely some familiar faces here, and also some new faces. So thank you for the opportunity to talk to you this evening. So surgery for breast cancer, this is going to be a little bit of a brief summary of what we do surgically for breast cancer. But basically, once you get the imaging and pathologic confirmation of a breast cancer diagnosis, particularly if you're dealing with early breast cancer, the next step is usually surgery. And so that's where the surgeon gets involved. So why do we do surgery for breast cancer? Well, it sounds a little primitive, but at least for right now, the best method we have for dealing with cancer locally is to remove it, to cut it out, and thereby prevent it from growing and prevent it from spreading. And so that also allows us to determine how extensive the cancer is, and that helps determine what other treatments might be needed after surgery. So the goals that we have for surgery are first and foremost to remove the cancer and to remove it as completely as possible. Secondary but very important goals are we want to minimize any disability that the surgery creates, and we want to maximize the cosmetic outcome after the surgical procedure. So this is very similar to a slide that Dr. Dawson just showed you, but just a quick review of the breast itself is made up of two basic components, the functional part and then the supporting stroma, which is the connective tissue and fatty tissue. The functional part is divided into the lobules right here. This is where the milk is made. And then the ducts are the little tubes, the milk ducts that carry the milk to the nipple. And this is a cross-section of a normal duct like Dr. Dawson showed you. The duct is these are the cells where most breast cancers originate. So the cells lining the duct is where most of them occur. The breast also has drainage. It drains fluid and lymphatic tissue through a network of tiny vessels. These are lymphatic vessels, and they drain to structures called lymph nodes. And the primary drainage of the breast is to the lymph nodes in the underarm. So lymph nodes are basically small little bean-shaped structures. They're a normal part of our immune system. They occur throughout our body, and they're concentrated in certain areas, one of which is the underarm. They function to drain fluid, to filter waste, and to help us fight infection. And for breast cancer, they are important because, as I said, when breast cancer spreads beyond the breast, the first place it usually goes is to the lymph nodes on the same side as the breast cancer. So evaluating the lymph nodes becomes important in terms of knowing how advanced the breast cancer has become. Is it still confined to the breast, or has it gone to that next step where it's involving the lymph nodes in the underarm? So sometimes the multitude of surgical options for breast cancer can seem a little confusing or overwhelming. There are different types of mastectomies, there's lumpectomies, there's breast-conserving surgery. So the question becomes, how do we personalize and how do we best select the most appropriate surgery for a patient? How do we decide if a patient should have breast-conserving surgery or a mastectomy? How do we decide if a patient should have chemotherapy first or surgery first? So a lot of things go into making that decision, but it's very key to make that decision both involving the patient as much as possible, so we know what her personal wishes and preferences are, and also involving all of the doctors that are going to be involved in treating that patient for breast cancer. The multidisciplinary approach that Dr. Hurwitz mentioned at the beginning of the talk is key for that. Some of the factors that help us personalize the breast cancer surgery include the size of the cancer, and in particular the size of the cancer relative to the size of the breast. That can push us one way or the other in terms of offering a breast-conserving surgery or a mastectomy. The biology of the tumor, how poorly differentiated is it, how aggressive does it look, what kind of receptors does it have. Those are some of the things that can help us decide if chemotherapy first may be more appropriate versus surgery first. The patient's personal preference is always important. Some women have a preference going in, even if they're a great candidate for breast-conserving surgery, to have a mastectomy. The general health of the woman is important. How much surgery will she be able to tolerate without any difficulty? And then the presence of predisposing genetic mutations like BRCA1 and BRCA2 play a big role in decision making. They're not very common, but if they're present, they definitely have an impact on our surgical decision making. So when we think about surgery for breast cancer, we divide it into two basic categories. One of them is breast-conserving surgery, and the other is mastectomy. So breast-conserving surgery, which is also called a lumpectomy or a partial mastectomy or a quadrantectomy, it has a lot of different names, but fundamentally, although the volume of tissue may be slightly different, the fundamental idea behind breast-conserving surgery is you want to remove the cancer and you want to remove a margin of surrounding normal tissue with that cancer, basically to ensure that you have removed all of the tissue. Sometimes cancers can't be felt, and if we want to do breast-conserving surgery in a cancer that can't be felt, we look to our imaging colleagues to help us either with ultrasound or mammogram, or in some cases MRI, to localize that tumor, so in the surgery we know exactly where to go and exactly what tissue needs to be removed. And this is a cartoon of a breast-conserving surgery with the tumor removed and a margin of normal fatty breast tissue around it. And here's an example of the appearance after breast-conserving surgery or lumpectomy. Has the obvious advantage of being less surgery, easier recovery, and usually very reasonable and good cosmetic results. It allows the woman to maintain her natural breast, her own nipple, and normal sensation. Mastectomy is the other sort of broad category, and this refers to basically removing the entire breast. So the tumor's removed, and along with that, all of the breast tissue. A mastectomy done without any sort of immediate reconstruction is basically a total mastectomy, and that also removes, in addition to the breast tissue, a portion of the skin of the breast and the nipple and areolar complex here. So this is the appearance that you might have after this patient actually had both sides double mastectomy. The breast is removed, the nipple areolar complex, and there's just a scar that goes across the chest wall there. With the advent of immediate reconstruction techniques, meaning the patient can have the breast mound reconstructed at the same surgery as the mastectomy. If the patient desires that and is a good candidate for it, we can do something called a skin-sparing mastectomy. And basically that shells out the breast tissue from underneath the natural breast skin. It includes the nipple and the areolar complex, but leaves all of this natural breast skin that can then be used for the reconstruction to improve the appearance ultimately of what the reconstructed breast will look like. And then Dr. Sang's going to show a lot more examples, but this is an idea of what it might look like. This is a reconstructed breast that's actually had the nipples reconstructed also. In some cases, if the patient is an appropriate candidate and wishes to do it, we can also do something called a nipple-sparing mastectomy. And that basically, in addition to saving the natural breast skin, also preserves the nipple and the areolar complex, and then the reconstruction is just basically done under the normal breast skin and nipple. The appearance of that can be excellent, but it's important to note that, first of all, not all patients are a good candidate for that. And second of all, the sensation is not normal. So the sensation is not the same as it would be in the natural breast, but the appearance is similar. So it used to be that surgeons believed that the more aggressive the surgery you did, the better chance you would have of curing the patient of cancer. But in fact, what we know now is that that is not really the case, and that if you appropriately select the patient for breast-conserving surgery, the outcomes are equivalent between lumpectomy with clear margins and usually followed by radiation versus a woman who has a mastectomy. So I want to talk a little bit about the lymph node surgery. This is an area where a lot of the more recent changes have happened in the world of surgery for breast cancer. First of all, when is lymph node surgery needed? And Dr. Dawson talked a little bit about this, the concept of in situ versus invasive cancer. And probably a lot of you are already familiar with this, but basically in situ cancer means that the cancer cells are still confined within the duct. They haven't invaded or broken through the wall of the duct. And because of that, they don't have access to the lymphatic system. They can't get into those little lymph channels that I showed you and go to the lymph nodes. So in this kind of a setting, evaluating the lymph nodes, especially if we're doing breast-conserving surgery, isn't necessary because those cells don't have access to the lymph nodes. Conversely, this cartoon on the right here, you can see that the cancer cells in the duct have actually broken through the wall and are outside the wall of the duct. This is an invasive cancer. Any invasive cancer, no matter how tiny, in theory has the ability to get into those lymphatic channels and therefore to travel to the lymph nodes. So evaluating the lymph nodes in this kind of a setting becomes important so that we can understand what is the extent of the disease and has it gone to the lymph nodes yet. So lymph node surgery basically has two purposes. One is to, if there are diseased lymph nodes or involved lymph nodes, you want to remove them. You don't want to leave them in the underarm so that they can potentially grow and continue to spread. But secondly, we want to determine if there are lymph nodes involved. If it's an invasive cancer, in many cases, if it's early, there aren't lymph nodes involved. So we need to figure out if there are lymph nodes involved, and if so, how many of them are involved. That will further determine stage and other treatments. So it used to be standard of care for anyone with invasive cancer was something called an axillary lymph node dissection. The axilla is the anatomic name for the underarm. And as I mentioned, that's the first place cancer from the breast usually goes. So an axillary lymph node dissection was very effective at performing both of those purposes that I showed you on the previous slide. Basically, through given anatomic boundaries, cleans out the fatty and lymph node bearing tissue. And then that gets sent for pathologic analysis. It's a variable number of lymph nodes. Usually it's between about 10 and 30 lymph nodes. And as I said, very effective at fulfilling the two functions that we want. The downside is it's a fairly extensive surgery and it can lead to complications following the surgery, the most common of which is lymphedema. Lymphedema is swelling of the arm on the side of the surgery, and it can occur in even as many as 20 or 25% of patients after an axillary lymph node dissection. So clearly a lot of women were having axillary lymph node dissections and then having no positive lymph nodes. So in the early 1990s, a technique was developed called the sentinel lymph node biopsy. And the sentinel lymph node biopsy is basically a technique that allows us to identify which lymph nodes in the underarm are the first ones that get the drainage from the breast. Then, using this technique, we can remove only those lymph nodes. Usually it's about 2 lymph nodes, occasionally it's 3, 4, but average is about 2. And minimize the chance of complications from the surgery, such as lymphedema, while still giving us the information that we need. And so the technique is done like this. You inject a tracer substance into the breast. You can use a blue dye called lymphozurin or isosulfan blue, or you can use a radio-labeled sulfur colloid, or you can use both. The most effective is when you're using both techniques. But you inject these tracer substances into the breast, and then the tracer gets taken up by the lymphatic vessels, and it travels to the lymph nodes in the underarm. And the sentinel nodes are the first nodes that drain the breast, concentrate that tracer. The surgeon can then make a small incision in the underarm and either visually or using a little probe that picks up radioactive counts, find the lymph nodes that are first getting that drainage and remove only those lymph nodes. Then, as Dr. Dawson showed you, those lymph nodes can go for very detailed pathologic analysis that's sensitive enough to even pick up single tumor cells and let us know exactly what's going on in the lymph nodes. So this technique is basically standard of care now for early breast cancer, and it's a very effective way to assess the status of the lymph nodes without subjecting the woman to a high risk of complications from the surgery. And a lot of you probably know about some of the more recent data that suggests that even in women who are having a lumpectomy who have small amounts of tumor in the sentinel lymph nodes, they may all not need axillary lymph node dissection. So in some cases, we believe we can actually avoid axillary lymph node dissection even if there are small amounts of tumor. So that is my whirlwind tour of surgery. So to summarize, basically, for breast cancer surgery, you can do breast conserving surgery or lumpectomy. You can do mastectomy. Most times you combine it with a lymph node evaluation, usually by sentinel lymph node biopsy if it's a clinically negative underarm. Surgery for breast cancer, like every other aspect of breast cancer care, is continuing to evolve as we learn more about the disease and understand more about the disease. Targeted therapies, I think, are the future, and Dr. Hurwitz is going to talk about that. But surgery itself is evolving towards less invasive and more cosmetically pleasing options for breast cancer patients. So on the cosmetic note, I'll introduce our next speaker, Dr. Singh.
Good evening, everybody. Thank you for joining us here tonight. It's a lot of information, and hope it's informative and both helpful. If there, of course, are any questions, we'll be here afterwards to answer those questions. But to continue our discussions, I'd like to present to you today an overview of breast reconstruction with a particular emphasis on many of the common questions that we receive, and also highlighting some of the newest techniques that we have in breast reconstruction. So really, who's a candidate for breast reconstruction? I think whereas in the past, commonly breast reconstruction was performed on women who underwent mastectomy, nowadays, with our technologies moving more and more towards lumpectomy, sometimes lumpectomy can result in a subtle change in the shape or appearance of the breast, or even a change in the size of the breast, and we can also reconstruct lumpectomy defects as well. But we'll discuss that in a little bit. As an aside, surprisingly, only 70%, about 70% of women who are diagnosed with breast cancer are not informed of their options for breast reconstruction. And so I think that that's what really highlights the importance of being in a multidisciplinary center where the plastic surgeon, the oncologist, the radiologist, and the pathologist can all be working together to establish a treatment plan that best suits each patient individually. So really, what is the goal of breast reconstruction? The goal of breast reconstruction ultimately is to restore the shape, restore breast symmetry, and restore the sense of feminine identity. And we can do that using a variety of techniques. But before we talk about the techniques, it's important to understand that reconstruction is always performed in multiple steps. It's never a one-off technique. The reconstruction is performed first to create the general shape of the breast mound. The second step is then to make subtle revisions to that reconstruction, either to optimize the shape or perhaps to make an adjustment to the other side to improve breast symmetry. And then finally, to make the nipple and apply the color to recreate the areola. And you can see here, after having gone through all three steps, this is what we can recreate in this day and age using a variety of techniques. I'm often asked about nipple reconstruction, and this is what nipple reconstruction can look like. So you can see that with nipple reconstruction, we're literally taking the skin of the breast, shaping it and folding on itself, and then typically using a tattoo type of an ink to add the color to recreate that areola there. And you can see that the nipple has the projection and the shape of a normal nipple, but doesn't have the function or the sensitivity of a normal nipple. So let's quickly talk about the options that we have in this day and age. Typically, when we're talking about reconstruction, we're talking about either using an implant type of a device to simulate the volume and the shape of the breast, or we can use your own tissues, typically from the belly area, to create the shape of the breast. If we first talk about the implant type devices, commonly this involves an expander implant reconstruction. This is a two-step process where the tissue expander is first placed underneath the muscle of the chest area and underneath the muscle of the skin of the chest. The expander is then inflated to both stretch out the muscle and the skin. And then about 3 months later, that expander is removed and then replaced with an implant. And that implant can be either a silicone implant or a saline implant. Some of the newer techniques involving implant reconstruction also incorporate the use of what we call acellular dermal matrix. Essentially what this is, it's a structural matrix that acts as an internal brassiere. And it both covers the lower half of the implant, and it acts as an internal brassiere to hold the implant in place and also to define the lower half of the breast, to define that shape and what we call the inframammary fold. And when we use the acellular dermal matrix in our one-stage techniques, it allows for placement of an implant immediately at the time of reconstruction, and thereby bypassing the whole process of tissue expansion, which we'll discuss again in a little bit. So here are some pictures, some examples of what a two-stage expander process involves. As you can see, starting from left to right, this is a woman preoperatively. In the middle panel, she's completed the process of tissue expansion, and so that tissue expander is really there to stretch out the skin and the muscle and to simulate or to create the first draft of the breast. And finally, in the third panel, all the way on the right, we remove the tissue expanders and replace them with silicone implants. And you can see that in this case, another important thing to also notice here is that implant reconstruction is commonly performed in women who are very thin and typically want to be larger breasted than what they started off with. Here's another example of a woman who's undergone two-stage expander implant reconstruction. You can see here again that this patient is very thin and that her breast reconstruction is much larger than what she started with. Now, we have a newer technique where we can completely bypass the process of tissue expansion and go directly to placement of an implant. And what that means is that we're essentially taking that silicone or saline implant and placing it underneath the muscle and skin of the chest to create the shape of the breast. Some limitations here is that the patients who select one-stage reconstruction are typically patients who want to be similar in size to what they started off with, and again, also who are thinner patients who may not have tissue to reconstruct the breast using other techniques. So if we look at the other options, typically what we're discussing is autologous tissue reconstruction, which is a fancy word for using tissue from another area of the body to reconstruct the shape and volume of the breast. Most commonly, Autologous reconstruction involves using tissue from the abdominal area. Most women who are at that age where they have developed or have been diagnosed with breast cancer usually have a small area of skin or excess fat around the belly that they've been thinking about a tummy tuck to address. And so the genius of this procedure is that instead of performing the tummy tuck and throwing that tissue away, we can actually take that tissue and transfer it to the chest area to simulate the appearance of a breast. So essentially what this is a breast reconstruction and a tummy tuck at the same time, paid for by your insurance company. So the major advantage of using your own tissues, again, one, unlike implant reconstruction, everything all the materials that we're using here are natural. They're all your own body. You get a tummy tuck at the same time, but it does require some microsurgery. So you have to be at a center like UCLA that performs this type of procedure on a regular basis and has very high success rates. And so when we're talking about reconstruction using our tissues, this is what we can expect in this day and age. We can expect very good symmetry, very good size, very good appearance, and then using the tummy tuck procedure, you get the improvement in the shape and contour of the abdominal area. And this scar that you see here on the abdomen is the same exact scar that one would see with a tummy tuck. And here's, again, another example of what we can expect in this day and age with, this is a patient who has undergone bilateral breast reconstruction using her lower abdominal tissues. So you can see that the breasts that were recreated have excellent symmetry, have excellent volume. Again, in this case, there's no implant that's been placed underneath these breasts. This is all of her own tissue from the belly area. And you can see that she has a good improvement in her abdominal contour, much as what we would expect with a tummy tuck. Now the nipple has also been reconstructed, and the areola has been tattooed to add the color. So one of the newer techniques, as I was describing earlier, is what can we do in a case of lumpectomy? So as Dr. Foster had mentioned, lumpectomy is the removal of that small area of the breast that's affected by cancer. In some situations, particularly in a woman who's smaller breasted, a lumpectomy can result in a noticeable change in the shape or the size of the breast. Whereas in the past, there weren't really too many techniques available to reconstruct it. Now we can essentially reconstruct that breast by using tissue from another part of the body, or in many cases, rearranging the remaining breast tissue to restore the shape and appearance of the breast. And so here's a case of a woman who underwent lumpectomy on the left side. As you can see, she had a much larger lumpectomy specimen removed, resulting in a noticeable asymmetry between the left and the right side. She was also very large-breasted and had been considering a breast reduction for some time. Given her asymmetry, and given the techniques that we have now, she's a perfect candidate for reconstruction using the tissue rearrangement techniques, where we are rearranging the remaining breast tissue to restore the shape and the symmetry of the breast. In her case, she also had a reduction of the right side to restore symmetry between the left and the right sides in this case. So really the goal of breast reconstruction, while it certainly is an elective procedure, is to restore the shape, the symmetry, and the feminine identity of the patient who's being treated for breast cancer. And we have a variety of techniques available. We can use tissues from the lower abdominal area. We can use an implant in a one-step technique. We can use tissues from the lower abdominal area again, leaving the nipple behind. And ultimately, the goal here is to restore that shape and the symmetry and the identity for a patient being treated for breast cancer. Well, thank you very much. And so I'd like to introduce Dr. Hurwitz, who will talk about the medical treatments for breast cancer.
All right, so my colleagues have very nicely reviewed the approach to a woman who has just been diagnosed with breast cancer. And I see there are some survivors in the crowd, I'm not identifying you, but some people familiar with the process of a new breast cancer diagnosis and the treatments available. And what I decided to do was to focus on only two things, because I only have 10 minutes to talk. Breast cancer therapy has evolved very quickly in the past 15 years for the systemic or medicine type treatments that we use to prevent it from coming back. And when we develop a new targeted therapy, a new therapy that goes after the malignant breast cells, we first test it in patients who have stage 4 breast cancer or metastatic breast cancer. And so what I want to do is share 2 stories that are rather late-breaking in the last year to explain the sorts of changes that are being made and strides that we are gaining in this field, to give you a snapshot of how our approach has become more personalized. So traditionally, what Dr. Dawson shared with you is the classification of tumors based on how they look under the microscope and where they began. And more, especially in the last 20-25 years, tumors are being classified not necessarily by whether or not they originated in the duct or the lobule of the breast, because that doesn't tell us what caused the cancer or how to treat it, but more and more we are classifying them by the molecular problems that cause them to behave like cancer and grow and divide and lose the ability to die when they are supposed to. And so that's allowing us to transition from treating the majority of breast cancers early and late with cytotoxic chemotherapy, which works by killing rapidly dividing cancer cells, and replace that therapy with therapies that target the molecular defect or underpinnings of that cancer. And so I'm going to give you a couple examples of that, but what I'm going to say is we are now in an era where targeted therapy is rapidly becoming available. And in order to develop a targeted therapy against the molecular underpinnings of cancer, it requires that you first understand what's wrong with those cells that makes them behave like cancer, and then you can develop a therapy to those cancer cells. But it's important that that therapy is targeting a problem in the cancer cells that's not commonly expressed in normal cells. If you are targeting something that's normally expressed in a normal cell, then you're going to end up with a more toxic therapy. And so you need both components. So one of the main examples of innovations in systemic therapy is that in hormone receptor positive breast cancer, this is one of the first examples of our understanding of what drives cancer. Dr. Dawson already shared with you that up to 3/4 of breast cancers are hormonally driven. They're driven by the female hormone estrogen. And so one of our first therapies was actually targeting that estrogen pathway. And in the last 2 decades or so, we are now seeing an era where new targeted therapies against the HER2 receptor and therapies in the near future targeting underpinnings of that basal-like or triple-negative breast cancer are going to be studied and available, hopefully. So here's the hormone receptor pathway. Here's your estrogen receptor that Dr. Dawson was talking about. You can stain it with a stain and look at the cells under the microscope, and if the estrogen receptors are in the cancer cell, you can see it that turns the cell brown. Estradiol, the hormone that is made by ovaries in women who've not yet gone through menopause, and by multiple tissues in the body with an enzyme called aromatase in postmenopausal women. Estradiol links into that estrogen receptor. When 2 receptors are bound by the estrogen, they actually travel together and they go in the nucleus of the cell where the DNA lives, turns on genes that tells the cell it's time to grow and make babies, and tells the cell to stop dying or lose the ability. It makes the cell immortal. And so a very targeted therapy is, well, you can remove the ovaries, the source of estrogen, if a woman is premenopausal, and that was one of the first therapies looked at in the 1880s. You can give a drug that blocks the action of estrogen, tamoxifen, I call it glue in the keyhole. It blocks the access of estrogen to the receptor. And then newer drugs, aromatase inhibitors, which block the production of estrogen in a woman who's gone through menopause. And these have literally altered the outcome for women. These are one of the most important therapies in all of oncology, not just breast cancer, because of the life-saving benefits of these treatments in terms of making cancer more curable, because it's been shown to prevent metastases. Now, the side effects are another thing to talk about for another night, but I'll leave it at the point that it is a life-saving, a very important therapy for many women. In the metastatic setting, if you give a woman who has hormone receptor positive metastatic breast cancer and anti-estrogen therapy, about 40% of them will have shrinkage of the tumor. And you give it to them until their tumor starts to grow back, and then you try a different form of anti-hormone therapy, and now only 30% of those women will have their tumor shrink. And with each line of therapy, you have fewer and fewer women responding to therapy because the tumor learns to live without estrogen. So the search is on, because this is the most common form of breast cancer and metastatic breast cancer. The search has been on for therapies that target that hormone pathway, or those mechanisms of resistance to hormonal therapies. And there's been a big breakthrough in the last year that stemmed from UCLA. One of my colleagues, Richard Finn, made an important discovery that's going to lead to very important findings, I would think, in the next 2 years. So I'm just going to show you this. I know it's dizzying, but what I want to explain is, for a cell to turn from one cell into 2 cells, it needs to go through something called the cell cycle. It needs to double its DNA copies before it divides into 2 cells. And one of the important checkpoints that regulates cell growth is called the R point. And there's a protein called CDK, cyclin D kinase 4/6, that regulates that R point. When CDK4/6 is really active, the cell can divide. So you'd imagine in tumors, CDK4/6 is very active. So a number of companies have made drugs that inhibit CDK4/6. We took this drug into our laboratory, and in our laboratory, we have 51 breast cancer cell lines. They're unique cell lines of breast cancer that originated from a patient at one point in the past. Some are hormone receptor positive, some are basal-like, triple negative, some are HER2 positive. And we looked at this molecule against the cell line. So each of these bars is a cell line. And the bars that have a really low amount here means those cells died when exposed to that CDK4/6 inhibitor. And what we looked at was, what are those cell lines that are dying that seem to be so sensitive to inhibition with this new drug? And it was a surprise to everyone. The drug company and we thought that it was going to be most active in very rapidly dividing breast cancer cells, the basal type, right? Because this is how it blocks the action of cell cycling. But what was found was it was the ER positive tumors that were incredibly sensitive, these blue tumors, to this drug. And so it was taken to a phase 1 study. I enrolled 6 patients in our clinic on this study, and we gave an aromatase inhibitor plus this drug, and the tumors just melted. But we have to be careful with phase 1 studies because it could be a fluke. You only have a few patients on the study. Importantly, the drug was really well tolerated, and this led to a phase 2 study where half the patients got the standard of care, letrozole, an aromatase inhibitor. All these women had hormone receptor positive metastatic breast cancer, and half got letrozole plus this CDK4/6 inhibitor. And what we looked at is how many patients had their disease grow and how long did it take for the women to have their disease grow back. Remember, they're metastatic breast cancer patients, so we expect the disease to grow back in a certain amount of time. And what was shown was those patients who received letrozole, the standard of care, 50% of them had their tumor growing back by 7.5 months. The median progression-free survival is 7.5 months. 50% of the patients who got the study drug still had not had their tumor grow back at over 26 months. These sorts of results in a phase 2 study are pretty unheard of. We don't see this a lot in the oncology world. And it is now a phase 3 study, global study, that's already enrolled over 100 patients in the world, and may become a reality in the next several years for those women with metastatic breast cancer, and several years later for early breast cancer that's hormonally driven. So this is how therapies are developed in the systemic setting, first in the metastatic setting, later in the early breast cancer setting. So that's for hormone receptor positive breast cancer. Dr. Dawson alluded to HER2-driven cancers. I'm going to show you this little picture here is that HER2 receptor. All the cells in our body have HER2 receptor normally expressed. 20 to 50,000 receptors per cell. We're not really sure why it's so important that all of the cells in our body have it, but it may rescue cells from cell death when they're under stress, especially heart cells. At any rate, there can be a genetic event where too many copies of the HER2 gene are made, and that leads to too much of that protein, up to 2 million receptors, being expressed on the cell surface. And when those receptors are overexpressed, they set about a domino effect inside of the cell. They turn on a relay race that causes the cell to divide and grow and turns off natural programmed cell death. So trastuzumab, Herceptin, is a therapy that's been developed intravenously. It has literally altered the outcome for and the natural history of this disease. It's available and FDA approved for all stages of HER2 overexpressing or amplified breast cancer, and data is now beginning to roll in showing just how important this therapy is both in the early and metastatic setting. So we knew about 15 years ago that HER2 positive breast cancer had the worst overall survival. Didn't matter where you tested the patients and looked at them, HER2 positive versus HER2 negative, HER2 positive always had the worst outcome. In the Herceptin era, we are now seeing that the natural history of their disease is actually better than HER2 negative breast cancer, and that's because of Herceptin. So this drug is very important. But we have to realize that in the metastatic setting especially, resistance still occurs to this therapy, and so a lot of studies are being done in the laboratory and in the clinic to figure out why some cancers don't respond to trastuzumab and why and why some develop resistance. So there are many therapies that have been studied. I'm only going to show you one as I round up this part of this talk, my section, and that is TDM1. TDM1 is trastuzumab, which is stably linked to a highly potent cytotoxic chemotherapy. The linker is so stable that it does not release or activate the chemotherapy until trastuzumab has bound to HER2, and this whole receptor complex is taken up inside the cell into this little organelle where the pH activates enzymes which cleave that linker and release the chemotherapy. And once released, the bomb goes off and the cancer cell dies. So this is the first example of truly targeted chemotherapy. And so we were involved, we looked at this in our laboratory. Again, really only HER2 overexpressing cells are sensitive to it. We were involved in the phase 1 and 2 clinical trials of it. And a year ago now, the Amelia study, which is a phase 3 study looking at this drug against the best available therapy, an all-oral anti-HER2 chemo regimen, was evaluated in almost 1,000 women with HER2-positive metastatic breast cancer. All of these women had had their disease grow while they were on trastuzumab and had received taxane chemotherapy. And what we see here is that TDM1 was not only better in terms of how long it took the women to have their disease grow more, it also led to an improved overall survival. This led to the FDA approval of this drug February 23rd, and at UCLA, we were the first site in the country to give the first FDA-approved infusion on February 25th. We had women literally lined up to get this drug. Although this is the most potent chemotherapy available, it actually can't be given unless linked to trastuzumab. Women don't even lose their hair on this drug because it's so targeted to the cancer cells. So we are now in an era where we have a marriage between our local regional treatment, and I'm going to introduce Dr. McCloskey, who's going to round up the local regional part of early breast cancer treatment, and systemic treatment. And with this entire husband and wife or wife-wife system here, we are really improving our ability to have long-term durable remissions or cures in the early breast cancer setting, and even with the hope for long-term durable remissions and possibly cures in the advanced breast cancer setting. So I'm going to pass the mic now to Dr. McCloskey to round it up with a talk on radiation oncology. Okay,
Okay, so down to the final talk of the evening. I really appreciate the attention that you've shown us, and I'm really going to wrap things up tonight by talking about what tends to be the final consideration we have in the treatment of women with breast cancer, which is the role of radiation therapy. I want to give you all some time for questions, so some things I'm going to intentionally skip through a little more quickly, but please do let me know afterwards if there's some questions about any of the details. So just as a very brief introduction, radiation therapy is certainly considered standard of care for virtually all women who undergo breast conservation, and I'm really going to limit my talk tonight to those women who have undergone breast conservation. We know that radiation therapy consistently decreases the risk of a breast recurrence by about 50 to 70%, and this does not only affect local recurrence but also has a breast cancer specific survival benefit. And just a very basic understanding of how radiation therapy works is it damages DNA of cancer cells, which is the genetic material that tells those cells how to grow and divide. Cancer cells can't repair that damage, and so they die. So just in terms of what I'm going to touch on, I'm going to talk most about standard whole breast radiation, which really does remain the standard of care. I'll talk about a few little emerging techniques and briefly about partial breast radiation. So when I see a woman with breast cancer who's undergone lumpectomy, the first consideration I have is whether I need to treat the entirety of the breast with whole breast radiation or just treat the part of the breast where the tumor was removed. And then in women who have positive lymph nodes, I'm thinking about, do those lymphatic regions need to be targeted with radiation as well, or just the breast? So in terms of whole breast radiation, the reason I'm going to spend most of the time here, this is the tried and true. This is the gold standard by which all other modalities are going to be judged. Typical course of radiation is about 6.5 weeks on average. Takes about 10 minutes a day to give. And in modern times, really what we want to optimize for our patients, we want to get that dose as even as we possibly can throughout the breast itself. And this has tremendous impact on skin effects from radiation. We also want to get the dose as conformal as possible, which refers to the tightness of the dose around the breast to avoid the normal underlying structures like the heart and the lungs, so we can avoid long-term consequences. So just to walk you all through just a very typical process for women undergoing breast radiation therapy, we first bring the woman in for a planning session. So this is just a CT scan in the treatment position where we map out the treatment field. So these are stickers attached to wires that we use to do this mapping process. We then transition all these images into our planning system, and on the computer we are able to contour all the structures we want to target with radiation and all the structures we want to avoid. So what this is an image of a breast. So if you see here what we have, so this is the left side of breast case, so we're treating the left breast itself. This is the tumor bed where the tumor was removed. And the structures we want to avoid are the contralateral breast, the heart, and the bilateral underlying lungs. Once we have those contours placed, we can then use those contours to guide our field placement. So this is a typical breast-only treatment plan where we have a beam entering from the lateral side of the patient and a beam entering from the medial side of the patient. These beams meet in the middle and treat everything in their path. You can see the entirety of the breast being treated with optimal sparing of the underlying heart and the underlying lung. One of the really important tools we have in modern radiation planning to achieve this conformality or field shaping is within the path of the beam as it exits the linear accelerator. We have all these little blue leaves. These are all metal leaves, and I have the wonderful privilege of being able to shape these exactly to my liking. So when I'm setting up a breast treatment plan, you can see this is the entirety of the breast as if you're looking from the beam, and I can shape these little leaves around the underlying heart. So this is the heart here. So that shaping really does limit any meaningful dose to the underlying heart as well as to the underlying lung. So this has really come to pass in my own lifetime, very new advances that we have. In terms of achieving dose homogeneity, this is a very complicated process that we use behind the scenes, but all of our wonderful dosimetrists and physicists who I worked with at UCLA, they're able to really take every individual breast case and shape these beams and give little beamlets within beamlets within beamlets to get that dose as even and homogeneous throughout the distribution as possible. This has tremendous implications for skin reactions, which I've also observed in my own lifetime. In terms of the treatment delivery itself, our women come into the room where the radiation is delivered. This is the big beam from which the radiation treatment comes. Our women come in and lie on the table in this custom mold that we've made to immobilize them each day, and the radiation comes out of the head of the beam. You don't see the beam or feel the beam. It's not painful in any way as it's being delivered. And typical skin effects, I actually had a hard time finding what a modern skin effect looks like, and there's a lot of variability in this. This is meant to illustrate sort of what a radiated breast looks like at the end of treatment. I don't tend to see as much of this peeling of the skin in modern times, more redness or darkening. And this is intended to indicate what we see at about 1 month later, which is primary resolution of most of those skin reactions. So in terms of emerging techniques, I'm going to talk about these really quickly. One is something we call breath hold. So I showed you the beams before, which come here side to side to treat the breast. And you see how close the underlying heart can be to the chest wall. So with breath hold, what we can do is we can have our women take deep breaths as they're being treated with radiation. And that serves to inflate the lungs, displace the heart away from the chest, and give us a nice clear path to travel. So it's an exciting technique that's coming into play recently. And then prone positioning, something where we can treat with women lying on their stomach rather than on their back. So this is great for women with really large or pendulous breasts, so they can really move away from the chest wall. I don't think it's as good, truthfully, for heart and lung avoidance as it is for just women with larger breast size. One of the techniques that I use more and more commonly these days, because so many women are now eligible, is something we call hypofractionated whole breast radiation. This is identical to standard whole breast radiation. We just give more dose per day and can do it faster. So it's really important to take each individual woman and see if they meet eligibility criteria for this type of treatment. But it's a nice way to improve upon our convenience associated with treatment. Finally, I'm going to touch on, last part, just partial breast radiation therapy, which is when we don't treat the entirety of the breast, but rather focus our efforts on that area where we think may be most at risk for breast cancer recurrence. So the rationale for partial breast radiation is the majority of recurrence in carefully selected women may occur right at the lumpectomy site where the tumor was removed. The nice thing about partial breast is really convenient. It can be done in about a week's time, and you expose less normal tissue to radiation. So there are very specific criteria for women to be eligible for partial breast radiation. I think the most important consideration truly here is patient selection. So in terms of the techniques, there are quite a few. I'm going to show you a picture of each one just to give you an idea. This is how this was originally developed, which truly looks barbaric, I think, by modern times, where the tumor bed was localized and we put multiple needles or catheters through that tumor bed to encompass that area at risk, and then treat with a little radioactive sources that would travel that distance. So the next advance was to transition from using multiple catheters to using just one. So this is something called a mammocyte, something called a SAVI. These are very similar conceptually, where a single catheter is inserted into that tumor bed and the radioactivity travels in those little channels that are available. So this, unlike that big linear accelerator beam I showed earlier, this is how partial breast is delivered through a little house for the radioactive source that travels through these cables and is connected to that catheter. So truthfully, the way that I do most partial breast in modern times is to use external beam radiation. The reason I like this technique so much is that most women have been through enough by the time they get to me and don't want to have another surgical procedure, something invasive done to insert that catheter. So we can do this treatment beautifully with the external beam radiation and really shape those beams just to that area where the tumor was removed. Final way that this is being evaluated is intraoperatively, and this is very interesting conceptually because all of the radiation dose is given at the time of this surgery in one large treatment. So this is the most modern type and certainly the type we have the least amount of data for. So I would say this really should be confined to clinical trials at this point to learn if this can be just as effective as the other modalities that we've used. So to conclude this part, radiation therapy certainly is a very critical component of the management of early stage and certainly more later stage breast cancer, which I didn't talk about tonight. And women today are modern techniques have really focused on two things, and that's convenience and really limiting the side effects associated with radiation. So that's our whirlwind tour. So I hope you're not all completely overwhelmed, and I hope we'll have some time to take some questions you might have. For us.
That we can address. Yeah, there's tamoxifen given post-menopausal women. I'll let Dr. Herbst address that.
It sometimes is. It's an oldie but goodie. I tell patients it's been around since the 1970s, so we know everything good about it, and we know everything bad about it. The aromatase inhibitors are a little bit better, so the standard of care is to start with them. They're a little better at preventing a breast cancer recurrence. to date, there's no significant difference in overall survival. The side effects are different, and some women tolerate tamoxifen better than aromatase inhibitors. And so it's an appropriate option for a woman who's tried the aromatase inhibitors and has too much in the way of joint pains, worsening of osteoporosis, joint stiffness, and so it's a viable option.
Can you speak to the 5-year versus now they're saying 10 years?
Yeah, I purposefully avoided that because I wanted to try and stay on time. So there are 2 large studies now that have reported later data on 5 versus 10 years of tamoxifen. It does not address 5 versus 10 years of aromatase inhibitor whatsoever. So these studies enrolled women who had early stage breast cancer that was ER positive. They compared 5 versus 10 years, and when they looked at the data around 10 years, there didn't appear to be a difference. Now that they followed both groups of women out about 15 years, they're seeing the women who took 10 years are living longer, significantly longer than the women who took 5 years. And what it appears to be doing, the survival curves appear to be separating in years 10 to 15, meaning when a woman's been off of tamoxifen for 5 years or longer, they start having more recurrences. Hormone receptor positive early breast cancer, in my mind, I liken it to a chronic disease. I want it to be silent and not rear its head until the woman's died at the age of 85 of something else. And that's when we'll know it's not going to come back. And so I always have my eyes open for the hormone receptor positive breast cancers because they can come back 20, 30 years later, which is why it's so important to try and impact it with that hormone therapy. And longer is probably going to continue to be shown to be better than shorter.
Thank you. And then also about I've heard about if someone is premenopausal, they start on tamoxifen, and then say they go into menopause and switch, and my oncologist had said that that's showing some of the best data to be half and half, and that's true?
We don't have comparative data of whether half and half is better than 10 years of tamoxifen. There's no such trial.
Oh, okay. So they just be
but
patient.
for now, it would be 5 years of an AI. Once a woman becomes menopausal, in a year or two, we should have data looking at 5 versus 10 years of AIs. The problem is these drugs have a lot of side effects and they diminish quality of life for the majority of patients, I would say. It's an unusual patient that says, I feel great on my aromatase inhibitor and I want to continue it. I have a few, but it's the minority. And so we have to take that into account, as well as bone loss, potential long-term cardiac effects, and other unmeasured things we don't know are happening in women.
Thank you.
Did you just say that the ER positive cancers are the ones that have the most recurrence?
Well, they are a slower growing tumor. They take a lot longer to declare themselves of being there. So a triple negative tumor we're all afraid of, but we're mainly afraid of them in the first 5 years, because if they're going to recur, they tend to recur quickly. A hormone receptor positive breast cancer, after 5 years, the recurrence rate for the triple negatives and even the HER2 positives goes down very low, but the hormone receptor positives continues at a steady rate for decades. And so it's not common, but that risk persists.
What do you feel about Lupron for menopausal women?
I feel that Lupron is an alternative if a woman cannot tolerate tamoxifen. We don't know that adding Lupron to tamoxifen improves outcomes. That data has not been presented. But there is one study that suggests Lupron or Zoladex compared to tamoxifen, compared to the 2 drugs together, have equivalent outcomes, and they're all better than doing nothing at all. So if I have a woman who can't tolerate tamoxifen or has endometrial thickening or other problems with it, I think Lupron is a viable option.
But you wouldn't combine them necessarily?
Some oncologists do, and it's not to say that that's the wrong thing. You get more side effects, and we don't know if it's helping more.
For the dense tissue breast, will you recommend you still need to have a mammogram or just ultrasound? Which way would be better for the dense tissue?
for evaluating women that have dense breast tissue, you want to continue to have your mammography as your primary mode. Even in dense breast tissue, you still have a very reasonable likelihood of detecting a breast cancer. Also, if you get new microcalcifications, malignant microcalcifications, you're going to likely see those in dense breast tissue. The real question is, and I think what you might be driving at is, should I have supplemental imaging in addition? You should always get your annual mammogram. Should you have supplemental imaging, for example, MRI annually? Are you in a high enough risk group to do that? For some women that have very high lifetime risk, MRI in addition to mammography is warranted. Other women, it's not. If you're just average risk, but you have dense tissue, should you have screening ultrasound? That's been very well studied, and screening ultrasound is basically doing whole breast ultrasound after a mammogram to look through the tissue and see what you can find. And what you find, if you look at very high-risk women with dense tissue and you do screening ultrasound in addition to mammography, you're going to find about 4 additional cancers per 1,000 women screened, 3 to 4 depending on the study. It's not that many. For those 3 to 4 women, it's huge. But to do that, you're going to biopsy 4 times as many women than if you had not done the screening ultrasound. And the outcome of those biopsies is going to be more than 90% of those biopsies will be negative, are normal. So it's a whole lot of work and a whole lot of biopsies for a small but very important benefit for a few. So you have to decide.
Can I tell the doctor, say, I want to have this done?
You absolutely can tell your doctor whether they will comply or whether your insurance will pay for it, which is irrelevant to many women, is another story. These days, there's a new dense breast tissue law, and now we have to report to women if their mammogram shows dense breast tissue. And that allows them to know they have that and allows them to open up the discussion with their doctor about potentially doing additional screening with ultrasound or MRI if they're very, very high risk.
Have there been any results or any medicines even initiated or research for the triple negative tumors?
Yes, there have been many drugs being tested and studied, but none that have been shown to be more beneficial than routine chemotherapy. There are trials. There's a very exciting trial I didn't have time to go over of a PARP inhibitor for patients who are BRCA carriers, BRCA carriers, and they tend to have a higher incidence of triple negative, and the results are very, very promising from the phase 1 data. Just presented 3 months ago. There's going to be another presentation at the end of this month in Amsterdam, very promising, and a phase 3 international study is going to be done, again in metastatic breast cancer, so not appropriate for a woman with early breast cancer, but certainly hopeful in the future.
The CDK46 you mentioned, is it possible, I understand it's in phase 3 now and it will eventually get to the early, breast cancer, but that might replace tamoxifen, is that?
It's given in conjunction with an aromatase inhibitor, so it's not being given as a single agent.
Okay.
It has been studied in a very small study, like 29 patients, as a single agent, and its activity is interesting, but it's not the home run. So when we take drugs into the early breast cancer setting, we never just replace the tried and true right off the bat. We usually add it to the tried and true and then see later if you can remove the other therapy. So for the time being and probably for the next 10 to 15 years, it will be in conjunction with anti-estrogen therapy.
You were saying the medicine is for the ER positive.
ER positive,
Okay. So that would be very, very good news for ER positive.
Yes, it's incredibly promising. We can't draw any conclusions from a 150 patient study, which is the only data we have from the phase 2 study. But the phase 3 study, which is going to have, I think, close to 500 patients, if that data looks as promising, the FDA is actually going to take an early look at that data before the trial is completed. And if the data looks as promising as the phase 2 data, they are granting it an accelerated process for approval before the phase 3 is even done. So it's that impressive that the FDA, that's what you heard about on the news.
So do you have an idea about when the FDA is going to?
It depends on the data. It depends on how well the patients do in the trial. No, I think that within 2 to 3 years we'll have an answer one way or the other.
Because a lot of people benefit from.
Absolutely. Absolutely.
Okay. Dr. Singh, what can you tell us about stem cell breast reconstruction? What have you heard about it? What is out there?
That's a great question. I think with regards to stem cells, the idea behind stem cells is to take a cell that can differentiate into multiple progenitor cells. The idea behind using stem cell for breast reconstruction is to take a cell from the body and induce that cell to generate into a new breast. Certainly that would be the ideal solution for breast reconstruction, because you obviate the need for an implant and you obviate the need to create or take tissue from another area of the body. Unfortunately, it's still very experimental. One of the techniques in which stem cells are being used is in fat grafting procedures. We're not using stem cells per se, but we're taking fat that's been suctioned from another area in the body and transferring that fat to help add volume to the breast. Typically, right now, we're using that for lumpectomy type of reconstructions, not for whole breast reconstructions.
There was a talk here like 6 or 8 months ago and about, I'm not going to say it properly, but something about freezing, about going in and freezing tumors.
What you're talking about is cryoablation.
Thank you.
And basically, it's definitely been looked at in breast. It sounds very exciting. It is exciting, but there's a lot of challenges associated with this kind of a technology that have remained challenging, but they're not done with it yet. They're working on it. So one day we may have this as an option, so Nova will have a new business or but we're not there yet.
Is there any time limit on reconstruction of breasts?
That's a great question, and one of the issues that I did not discuss was with regards to timing. And in fact, there are no time limits on breast reconstruction. The pictures that I showed today were reconstructions that were performed at the same time as the mastectomy, and we call that immediate reconstruction, meaning that we perform the reconstruction at the immediate time of the mastectomy. But reconstruction can also be performed in a delayed fashion, which means that the mastectomy is performed, the patient heals from the mastectomy, and then the reconstruction can be performed 3 to 6 months later. Most commonly, it's performed after additional therapies like radiation therapy or chemotherapy is completed. And so in the delayed setting, reconstruction can be performed using implants or using your own tissues.
Okay.
So there is no time limit, and there's no time limit in terms of insurance coverage of breast reconstruction either.
There's no insurance problems then either.
No,
So if someone decides like 3 or 4 years later, they didn't want it, and then they decided they wanted it, it's not a problem.
Absolutely, that's not a problem at all.
What would you recommend in implants? Because I heard there is a saline and the other one, I don't remember the name.
Silicone.
Silicone, yeah.
Right, that's a very common question as well. So really, I think the heart of the question is, what is the difference between a silicone and a saline implant? And when I speak with patients, I kind of make the analogy of a jelly donut. You know, an implant is kind of like a jelly donut in the sense that the donut portion of this jelly donut is always made out of a silicone shell. So that portion is the same regardless of whether or not it's saline or silicone. What goes inside is the differentiating factor. So in a saline implant, it's saline fluid, and in a silicone implant, it's silicone gel. The saline fluid is very similar to the fluid that is in our blood. So if you break a saline implant, that fluid that leaks out will be absorbed into your body just like water. In comparison with a silicone implant, if you break a silicone implant, the silicone is not going to be absorbed by your body. So typically, it's very difficult to know if you have a problem with an implant, and the manufacturers recommend either an MRI at 3 years after surgery and then every 2 years after to check and look at the integrity of the implant. And then there's another question that I think might lead into this is, what are the health or potential side effects of having a silicone implant? So the FDA mandated a 10-year study that was completed in 2010, and they were looking at whether or not silicone implants cause any of these systemic illnesses like lupus or fibromyalgia. And in fact, they showed that there was no definitive link, and that, therefore they authorized silicone implants to come back on the market for both cosmetic augmentation and also for breast reconstruction. Now, just to kind of go into a little more detail about silicone implants, we're currently on the 4th generation of silicone implants, and what that means is that unlike the very first generation where if you broke an implant, the silicone would just kind of ooze out, the silicone gel that's being used now is called highly cohesive. You can kind of think of it like Jell-O, in the sense that if you cut through Jell-O, the Jell-O is not going to just ooze out. The Jell-O will just stay there and hold its shape. And so these highly cohesive gel implants are very similar in the sense that you can break the implant, but the silicone will hold its shape. That doesn't mean that we recommend walking around with a ruptured implant, but it's not something you have to worry about it leaking out of its capsule and leaking into other parts of the body. Great question.
Camera.
Unless I've missed something, I hear a lot of, apart from HER2, hear a lot of talk about estrogen positive, progesterone positive. I don't hear much about what drugs are affecting progesterone. It's mostly the estrogens that I hear about. And what happens if you're not progesterone positive, you're progesterone negative? Then how do you deal with that?
Progesterone receptor negative tumors. Progesterone receptor is a protein that's made pretty much only in the presence of estrogen receptor. If the cell is doesn't have genes turned on to make the estrogen receptor turns on genes that allow the progesterone receptor to be produced. So a cell that is highly dependent on the estrogen pathway has both estrogen and progesterone receptor, and it indicates probably a better long-term outcome and probably more responsiveness to anti-estrogen therapies if both receptors are expressed. If the PR is lost, it indicates that there are other pathways and other signaling pathways, other molecules in that cancer cell that are driving the cell to divide and grow. And it may not all be estrogen receptor pathways, so you may not put all of your money in that basket. You may use anti-estrogen therapy, but also in conjunction with features like grade, size, lymph node status, patient age, lymphovascular invasion, decide maybe should we add chemotherapy as well. Anti-progesterone therapies have been looked at. They haven't been terribly exciting so far in clinical trials because it really is the estrogen is the primary driver of the cancer. Androgen receptor targeted therapies are being looked at and may be exciting. Androgens are like the male receptor, and that may actually be a therapy that's effective in triple negative breast cancer because some of them carry the androgen receptors. So the hormone receptors in that diagram I showed you is an incredible oversimplification of the process. Our understanding is probably the tip of the iceberg. As we learn more and more about these pathways, we recognize how little we have actually known. So it's an evolving field.
What causes hematoma? Does it has anything to do with surgeons still?
It's very unlikely. I mean, it is a complication that you can have after any surgery, and when you do a mastectomy on a woman, you leave a relatively large potential space. So if there's a small amount of bleeding that just doesn't stop for whatever reason, because the blood isn't clotting normally, or just because it just isn't able to clot, it can accumulate in that space, and then it basically turns into what we call a hematoma, which is just a big area of clotted blood. And sometimes, if they're significant enough, we go back and remove that clotted blood so that everything can heal back down. If there's just a little bit of bleeding, the drains that are in after a mastectomy usually will deal with it, and eventually the bleeding will stop. But it can happen to any surgeon and to any patient, and it's just a rare but described complication. In the absence of a bleeding disorder that you might personally have, there's no reason to think you would be at any increased risk of a hematoma if you had a mastectomy on the other side. So I think it would still be incredibly unlikely, but not impossible, that you would have that complication on the other
So it
side.
has nothing to do with system.
I don't think so. It's very unlikely.
Two quick questions. One is about the sentinel node biopsy. When we were talking about that, there was a mention of when the testing is done, that there's an extra testing or something that's done looking for the smaller molecules. Is that a standard test, or is that?
Yeah, so you're talking about what Dr. Dawson mentioned, immunohistochemical testing,
Yeah.
and that's a special stain that is done on sentinel nodes that's very able to pick up very tiny deposits of tumors, even sometimes isolated tumor cell deposits.
Okay, that's a
So-
standard for, yeah, when you're doing the sentinel node.
Right,
Okay.
but I think universally, but certainly at UCLA, that's done standardly on sentinel lymph nodes.
Okay.
So we do a certain number of levels, and we do a certain number of immunohistochemical stains on all those levels to ensure that we're targeting any cell that might be.
Great, thank you. And then the other question was a surgery question. You were talking about the one step of not having the expanders put in first, just going right to the implant. Is the implant then placed in a different location than it would be if you did the expanders first?
That's a great question. So when you're using any form of an implant, be it an expander or an implant in this technique that you're describing, we always place the implant device underneath the muscle. And the reason is because we need to have the muscle cover the implant, both to help camouflage it, but also to protect in case there's any problems with some of the incision breaking down and exposing the implant. So it always goes underneath the muscle.
Okay, so and is there a recommendation of, because I heard someone recently talk about not supposed to do any stretching of the muscle, but then, I mean, if they're not doing any kind of stretching, then everything gets tight and uncomfortable. So I hadn't heard that before, that someone said not to stretch the bicep. One of the surgeons told them not to stretch the bicep muscle at all, and that sounded a little.
I think in general, we recommend not performing any really heavy physical exercise immediately after the reconstruction, because we want to make sure that the muscle itself has time to heal to the skin, and also to allow the alloderm, which is something, the acellular dermal matrix, which is something we use now, to also heal to the skin. And so if a patient is very active immediately after surgery, then sometimes they can cause a problem with the muscle covering the implant, or potentially even cause a large accumulation of fluid underneath the skin, which might require additional surgery to correct.
Okay, but you're talking about heavy lifting, and you said immediately after, just with how many months? Like usually within 4 months, 6 months?
So typically I allow my patients to start resuming physical activity with their arms at about 4 weeks.
Okay.
So, but they're fully active immediately after surgery, but just in terms of using the arms for any physical activity, usually it's about 4 weeks.
4 weeks, okay, thank you.
So we're going to wrap it up now. It's almost 9 o'clock. Robin, our navigator, has some cards. If you want to get in touch with us, we're all available offline. You're welcome to email me. Robin's got all of our
There's some
contact
brochures in the very
information,
back.
and there's brochures as well back there. But thank you for your attention so late in the evening, and we hope that it was informative for you.